three experts on the field who will each of them address a different part of this aortic disease puzzle. And I would like to invite Andrea to present the first speaker.
Thank you, Laura. I'm also very thankful for everyone here. And we will have a first talk on a very interesting topic on red flags in pediatric aortopathies, on cases we should not miss, by Dr. Gianluca Ragazzoni from GOSH, London, UK. And we are all very pleased to have him here. So thank you, and the floor is yours.
Gianluca, just give me a second before starting your session. I would like to mention that we will take all the questions after each session. And if you would have any questions, please use the Q&A box in order for Andrea and myself to be able to see them and post the questions to the speakers. Thank you.
Thanks. Good afternoon, everyone, and thank you for the introduction. So this afternoon, I would like to present you with three cases that are not only centered on the aorta, but I'll show you that when we look at this patient, there are other things we should take into consideration. Oh, sorry, that's the wrong. So for our first cases, we have a 6-year-old female with deletion of the exon 24, which is one of the regions that is related with a more aggressive disease. And as a matter of fact, this patient had ectopia lentis, mild scoliosis, severely dilated aortic root, and a mitral tricuspid valve prolapse with moderate plus mitral regurgitation. She was on losartan 25 milligrams and atenolol 10 milligrams twice a day. So when we look at her echo, of course, we can see that the aorta is quite significantly dilated, but we shouldn't stop there. We shouldn't stop at measuring the aorta. When we do the cardiological evaluation of these patients, we should also look at the mitral valve. And here we can see that the mitral valve is quite dysplastic, it's prolapsing, there is quite a bit of regurgitation, but also we have the mitral annular disjunction. It's not so easy to see in this images, unfortunately, but you can already see that the movement of the myocardium in the long axis is not completely normal. And then when we move on to the MRI, we can clearly see on the image on the left that there is some separation between the mitral annulus and the myocardium. And now, why is this important? Well, the link between the mitral valve collapse and the risk of arrhythmic death has been known for quite a while now. So the first study on this date back to the 17 and early 80s, where another autoptic study, and more recently another autoptic series from the group in Venice of Cristina Basso linked the mitral valve prolapse with sudden cardiac death. And so these are the recommendation of the European Heart Society, and you can see that when we have patients with mitral valve prolapse, they should undergo a structural risk stratification process aiming at identifying the risk of sudden cardiac death. And specifically, one of the things we should look for is the mitral annular disjunction. And why so? Because this is one of the features that's more strongly linked with the arrhythmic events. So you can see here in the study that patient that had a mitral annular disjunction had a higher risk of having arrhythmic events. And so there are recently also some study that have shown some correlation with the mitral annular disjunction and arrhythmic events, even in the absence of a true mitral valve prolapse. However, there are not that many long-term data. And so for the time being, I think that, and especially also in the EHR consensus statement, they were just referring at MAD related to the prolapse. But I think it's good also to keep in the back of our mind that when we see MAD, we should always start thinking about arrhythmia risk, even in the absence of the prolapse, although this might not be a higher correlation. But what this, of course, where studies on the general population, what happens in the patient we see, and in Marfan patient, for example. So this was a study that was conducted on a patient with Marfan syndrome, and we can see on the right that the patient that had the MAD had a higher risk of having ventricular ectopies and non-sustained VT. But the author didn't stop there. They also looked at MAD tertiles. So they divided the patient based on the length of the MAD. And what they saw is that the patient that had a higher degree of MAD, at a higher risk of ventricular ectopy and non-sustained ventricular tachycardia. But not only. We can see that patients with MAD were the one that had ventricular tachycardia or sudden cardiac death. And again, this patient were the one with the higher degree of MAD. And when we look at aortic events, so not only of arrhythmic risk, but the MAD might also be a marker for more aggressive disease. And when we look here on the left, we can see that patient that had a MAD had a higher risk of having aortic events, although this did not reach statistical significance. But again, when the authors divided them in the third chart of MAD, they can see that patient that had a high degree of MAD had a high risk, and this in this time was significant, of having aortic events. And so going back to our patient during the consultation reported 2 episodes of loss of consciousness. On the first episode, she was at home, she stood up, she started feeling dizzy and subsequently collapsed for a few seconds. The second episode, a little bit more concerning because this was during exercise. She was in a field trip with her school. Again, she started feeling dizzy and subsequently collapsed. She had an event monitor prior to this consultation, and this is what we saw. So we see here that we have some arrhythmias. We have 2 episodes that were quite concerning. So what we did at this time was she was implanted with a loop recorder. And to be honest, this was around a year ago, and we haven't seen any more episodes, or we haven't seen any concerning arrhythmia or on the loop recorder so far. But I think that when we have patients with a mitral annular disjunction and mitral valve prolapse, we should always think of the arrhythmia risk, and we should at least do a Holter monitor. Now, for a second case, this is an 11-year-old with a TGF-beta receptor 2 mutation. She had severe aortic dilatation, so the level of the sinus valsalva was 42 millimeters with a Z-score of plus 7.9. Again, here we can see that she has a quite severely dilated aorta. The mitral valve is again dysplastic. There is a little bit of prolapse, although there is no significant regurgitation. Another thing that we should look for, though, apart from the mitral valve, are the vertebral artery. And you can see here that she had quite a tortuosity in her vertebral artery. And now you may ask, why should we look for this? Why should we be interested in the vertebral artery of a patient with Lloyd's? Shouldn't we just be focusing on the aorta? Well, from the reason why I look at the vertebral artery as well is because of this study from 2011. What the author did here was create an index based on the length, the actual length of the artery and the theoretical length, so the length between point A and point B. And you can see on the left, this was a patient with Lloyd's disease, and the vertebral artery was quite a tortuosity in it, opposed to the left where we saw, to the right where we see a control patient, and we can see here that the actual length of the artery is almost the same as the theoretical length. Now, is this just a feature? Well, when they looked at control patient, they look at Ehlers-Danlos patient, they look at Marfan patient, they saw that in Marfan syndrome patient, the tortuosity started to be a little bit higher compared to the other groups. But this was even more evident in the Lloyd's disease patient, where they had a significantly higher tortuosity. Now, why is this important? Is this just a feature of these patients, or is something that is informative to us? Well, it is informative, and you can see here that when we look at when we divided patients based on the tortuosity index, the patient that had a tortuosity index above 50 had a significantly higher risk of needing prophylactic surgery. And this was as a study done on pediatric patients with the vertebral tortuosity index. So going back to a patient, these are the guidelines from the American Heart Association. And you can see here when we have a TGF-beta receptor 1 patient, we should look for higher risk feature. And one of the higher risk feature is the marked arterial tortuosity. So in this patient, where we have a marked arterial tortuosity, an aorta above 40, what should we do? Well, if we look at a recommendation for children, we see that if the patient is above 5 and the aorta is above 4 with high risk feature, we should consider surgery. And so this patient underwent surgery and had a valve sparing aortic replacement. Now, is this the end of the story? Well, unfortunately not. This is 3 years later. This was actually the beginning of the month. She had a control CT and showed coronary batten dilatation. And I actually asked our engineers here to do a 3D reconstruction of her aorta. And you can see that especially the left coronary batten is quite dilated, but the right is as well. And so this technique, we can, of course, do the 3D reconstruction, which allow us to look more in depth of the aorta and have a better understanding. But we can also do the slicing. And again, we can see here some nice images playing with the 3D, where we can have some images close what we see with the normal CT, and we can look at the coronary battens. But we can also slice, and this is mainly useful when we have, for example, the anomaly origin of the coronary artery, where you can slice through and go in, and sometimes it is easier to see it in these models, for example, how the ostium look like. So sometimes we like to look at the 3D reconstruction as well. Now, moving on to our third patient. So this was a 12-year-old male with a bicuspid aortic valve. He also had a aortic coarctation that was repaired shortly after birth. He has a severe aortic root dilatation, 40 millimeters at the level of the sinus valsalva, with a Z-score of plus 6.47. And he's also heterozygous for a VUS in the TGF-beta receptor 1 gene. Now, you may ask, why did you do genetic testing? Of course, we're normally told that in bicuspid aortic valve patient, we shouldn't be doing genetic testing. Well, yes, you'd be correct. But in some cases, genetic testing should be considered. And for example, when we have, in this patient, we had an early presentation, the dilatation was not explained by the degree of the valve disease. And as a matter of fact, you can see here from the echo images, there was almost no regurgitation, and when we look at the gradient, there was no stenosis, but we have quite a bit of aortic dilatation. And also it has aortic root phenotype, which by itself doesn't tell us much, but this is the phenotype that is more associated with the underlying genetic cause. So again, when we take this, we should take this into consideration with the fact that the valve is not that damaged and is an early presentation. So in this case, that's why we did the genetic testing. Other cases where genetic testing should be considered might be a strong family history of dissection, or for example, if there is a high familial clustering of bicuspid aortic valve and dilatation, or sometimes we may have some dilatation in first-degree relative, even though they have a tricuspid aortic valve. So now the question with the patient was, what should we do? Because of course, again, we have 12-year-old bicuspid aortic valve, but the valve itself is not is almost normal function, and we have a 40 millimeters at the level of the sinus valsalva with a Z-score of plus 6.47, and the VUS in the TGF-beta receptor 1 gene. Now, if this VUS was considered to be actually pathogenic or likely pathogenic, then we may be considering an operation, as we are just sitting on the threshold. However, with this patient, what we did is we talked and had a discussion with a cardiac geneticists, and at the end, it was felt that this was a benign mutation. However, the patient still had quite severe dilatation, and also it was quite keen on sport participation. So they were evaluated at the Velina, and ultimately they had a PAIRS procedure, which is a personalized external aortic root support. So what happens here is they do a 3D reconstruction of the aorta, and then based on that, they print a 3D sleeve of the aorta, and this is surgically implanted on the outside. And the idea is that it will support the aortic wall from the outside and prevent a further dilatation. This was a procedure that has been studied by actually an engineer that came up with this because he didn't want to have, I think he didn't want to have the aortic surgery. So what happens? This is the echo at the top left. We have the echo pre-procedure, and at the bottom right, I have the echo post, and you can see that the shape of aortic root now is very similar to the sleeve I showed you before. Now this is SEC again. We can see there's a mild aortic regurgitation, but unfortunately the patient develops a mild right ventricular dilatation with mild systolic dysfunction. There was a moderate tricuspid regurgitation and also moderate left ventricular dysfunction. Now, with this patient, there was a discussion about extending the genetic panel to the cardiomyopathy genes. Unfortunately, it has been transitioned since when we did these echoes, he had already been seen by the adult center. So I don't have, unfortunately, the end of the story today. But so to conclude, in patient with connective tissue disease, the cardiac assessment should not be limited at the aorta. We should look at the mitral valve, and the mitral annular disjunction is a risk factor not only for the arrhythmias, but also for more aggressive disease. When we have patient with low HDS, we should assess the vertebral tortuosity at least once. And in selected patient with the bicuspid aortic valve, we should also be considering genetic testing, as there might also be a genetic underlying cause. Thank you for the attention. I will stop sharing now.
Thank you very much for the amazing talk. If you don't mind, I have one question. In regards of mitral annulus disjunction, when would you consider and all the relationship with risk with arrhythmias, tissue characterization with MRI or lead gadolinium enhancement? Do you think there is any role in assessing the any fibrosis, a scar or tissue in those patients?
Yeah, I think we should, and I think when we do the MRIs, and especially in children, when we tend to do the MRIs more than the CT scans, it's good at least once to look for late GAD. But we should be careful when we do so, because the late gadolinium enhancement that is associated with arrhythmic risk in the mitral valve prolapse is the one on the papillary muscle and just around the mitral annulus. So we should look for the late GAD, but we should also take in consideration where it is. And it is well shown also in the autoptic series that the mitral valve prolapse, and especially when we have the disjunction, that is related with some fibrosis. Why this happens is probably due to the movement of the mitral valve that creates some tension around the annulus, because we have an abnormal movement, and also on the cord, and so sometimes we can have some fibrosis of the papillary muscles.
Thank you.
And I think we should also look at where the arrhythmias come from, because that's another important factor. So if they're related to the mitral valve, we should, or if there is LG, we should look whether they come from that region or not.
Thank you. Continuing with the topic of mitral annulus disjunction, would you say, or do you know, is it only associated with Marfan syndrome, or do you think there is also this feature in other aortopathies, and has this also been associated with arrhythmias in the other aortopathies other than Marfan's?
I think speaking, like generally speaking, and most of the series where they do the mitral valve, where they looked at mitral valve prolapse, it was not limited to, there was all comers, so all the patient, and we know that the mitral valve prolapse is more evident when we have some congenital disease. Whether I would consider this a risk given patient with low LCS, for example, I think we should, because regardless of why we have the mitral valve prolapse, I think that if we have the fibrosis, that is a substrate, and we know that substrate may be related to arrhythmia. So I think that we should be looking at it anyway, but I think that's something that we want to look at study-wise, whether we have that in low SDS as well. And I think we need more data, but ultimately at the moment, I think that when we have a mitral valve prolapse, especially if we have the mitral annular disjunction, regardless of the underlying cause for it, underlying genetic cause, we should be looking for the arrhythmic risk.
Perfect. Thank you. Last one, when we are talking about the high risk low SDH patients, we include part of also as you said, tortuosity, scores, and systemic features as well. But what do you think are the limitations in children? That some of them, maybe this is more sometimes in Marfan, so that in children they have not so obvious features sometimes. What do you think are the limitations of the systemic scores in children and aortopathies in regards of the examination?
You mean when we look at the patients?
Mm-hmm.
Yeah, of course, this is a problem, and we actually have. I saw a couple of weeks ago a family where none of them look Marfan at all, but they all have an aortic dilatation. They are quite young. They have the mitral valve prolapse with mitral annular disjunction. So of course, and that's why I think there are some talks, for example, part of my background is in sports cardiology, and some of it is whether we should screen someone with an echo at least once, because sometimes otherwise we might miss this case. Of course, every time any doctor should see the patient, I think we should take a very good family history to see whether there is any history of aortic dilatation or aortic events. But ultimately, I think that at some point when the kids an echo, even a fast echo, is something that should be done.
Thank you. Thank you very much. Very, very nice presentation. Thank you.
Thank you.
Thank you, Gianluca. It was indeed a very nice presentation, featuring indeed some of the very important things that we don't always look at in our patients. We have just a few minutes before we go on to the next speaker, and I just wanted to also ask one question, Gianluca. You spoke indeed about the tortuosity and the importance of the tortuosity index in breast stratification. In some cases, we look also further than the vessels or at the neck, and we look at for example, cerebral arteries and these type of things. Is it something that you do routinely? Are there a specific group of patients would you think we should also look at for example, cerebral arteries?
Yeah, when we do it most of the time, we include the head, especially for the one where we think they have high risk, and other patients where we also look for the head vessels. For example, the Ehlers-Danlos syndrome, we look for all the vessels, and when we have very aggressive mutation as well, I think we shouldn't just focusing on the aorta, because the risk is that there are other places where we can have aneurysm and we can have dissection. So especially when we have high risk features, we shouldn't be just focalizing on the aorta only.
Okay, perfect. Thank you very much. And I think with this, I will go on to introduce our second speaker, Elena Cervi from the Great Ormond Street Hospital. I have the feeling that Elena does not really need introduction, because she's really a true expert here in Europe on aortic disease. She sees many children with these conditions, and she will speak today about the variability in the phenotype, the diversity, and sometimes the nuances on this phenotype. Elena, the floor is yours.
Thank you, Laura, and thank you, Andrea and AEPC for inviting us, really. So Gianluca has very nicely gone through some of the cases that we come across in clinical practice that give an impression of the fact that, yes, we're not just looking at aortas, the phenotype is expanding, and we have a lot more awareness now of the multitude of cardiovascular presentations that we can have with inherited aortic diseases. I thought I would actually go back to more basic things and to give people an opportunity to ask any questions they might have. So when we think about the spectrum of pediatric inherited aortopathies, the question is really why do we want to screen children for this? And it all comes down, I think, to me, is when in the 80s we started looking at sudden death. Of course, there are some very obvious culprits, so inherited arrhythmias and heart muscle disease, but in a corner you will always find that there was someone that presented with a vascular event and they died because of a ruptured or a dissected aorta. So I think we want to capture those. We want to make sure that although the incidence of dissection is very small in children, that we're not missing on anyone that could potentially have an actionable disease. So aortic disease, with that we mean a progressive disruption of the arterial wall integrity, and that can manifest itself with dilatation or not. And we now know that there are some conditions where actually the risk is there, even if the aorta doesn't look particularly dilated on your scans. And of course, the ultimate goal is to prevent dissection or an acute aortic syndrome. What we're more familiar with in pediatrics is a picture like this, what you see on your right-hand side panel. So a dilatation that is quite prominent at the aortic root, so the sinus of valsalva being dilated with the rest of the aorta probably looking rather normal. But we know that aortic dilatation can happen really at any point of the aorta, including the root, ascending, the arch, the descending. And it is, of course, more common in a lifetime in the abdominal aorta, just because of the composition, how the aortic wall is actually built up in different parts of the aorta, which is one of the biggest organs of the body. And there are specific mutation and very different genotype and phenotype that code for aortic aneurysm in the proximal or in the descending and distal aorta. And what we want to avoid, of course, is starting from a child with a tiny bit of aortic root dilatation to end up with an aorta that looks all dilated and that might require a lot of attention through a lifetime. With dissection, which is the ultimate goal, is try to prevent it, is an intimal tear in the intimal and medial layer of the aorta. So it's basically different layers of the aorta coming apart. There is a tear, and then the pathology is driven by the blood pressure, and depending on where the classification is based on where the tear happens, and then what is the propagation. And the symptoms will be very much related to what organs are involved. So if there is a loss of flow to any organs and systems that are involved in the dissection. And I think back in med school and in my adult cardiology experience, you have a clear picture in your head of how a patient with aortic dissection presents like. So the textbook description is a sharp and excruciating pain in the chest, then travels to the back and extends basically according to where the dissection flap is extending with migration and with pulsosymmetry and a number of other things. And of course, it's a very difficult thing to think about, especially in some settings, because it's been always recognized that aortic dissection can mimic many other syndromes that are much more common, especially in adult practice. But we also know, especially in pediatric, that dissection can present in a completely different way with much more subtle symptoms and not the ones that you would be more familiar with. And the importance of that is that aortic dissection still nowadays, even if the numbers are improving because of the improved recognition in the community and care provided, it remains a surgical emergency. And there is still a big discrepancy between the numbers that you get from the reported incidents in hospital cohorts and the autoptic series, meaning that a lot of them still die without coming to medical attention when they're still alive. When do you need to be concerned? When you see something, always, but when you see someone that presents with a dissection on an acute aortic event young, so we usually say before 40, and especially if it is around the time of a pregnancy or soon after delivery. So all of those things are things that should make you think, is there anything in this person that puts them at risk of developing an acute aortic disease? And of course, the treatment is surgical. low, but the mortality, as said, is still very high. And you can imagine how it is even more difficult when you present to pediatric A&E with chest pain and your A&E looks like this. Nobody would really think about aortic dissection, and this is where you see a poster on the side. This is a big campaign that was launched in the UK to raise awareness and to make sure that people thought aorta when someone came in with symptoms that were suggestive. Is it that relevant? Well, when we think about acute aortic events, this is a relatively recent surgical series looking at almost 8,000 type A aortic dissection patients in international court, European mainly court, and this is, as I said, it's surgical. So of the 8,000 patients, only 139 were young adults, so below age 30, and only 6 were below 18 years of age. So it remains a very rare event for children and young adults to present with aortic dissection. But of course, the importance is try to tease out the ones that might be at risk. And when you think about the etiology of aortic diseases, it's a complex background. But of course, I feel like as pediatric cardiologists, we are a bit privileged at times because some of these things have not happened yet, and some of them are down to the wear and tear of your aorta. So having high blood pressure or having atherosclerosis, so acquired diseases that just make it likely for your aorta to age more quickly than it should. But all of those things probably haven't happened in a child. So you're left with a pretty streamlined model of disease, where the things that you need to have in mind is there anything in the background? Is there possible inherited aortic disease here? Do they have congenital heart disease? Because we know that some conditions tend to associate with aortic dilatation. So those two things are the two big culprits when you see someone with aortic dilatation. And then we have some other things that, of course, we wouldn't be particularly happy to see in terms of pregnancy and drugs that might trigger an aortic event. So we're left with a concept where if you see aortic dilatation in a child, probably you want to investigate it. It's not something that is commonly seen, and I'm sure probably Simona is going to talk about management. We'll touch on how we measure aortas in children and how it gets more complicated when you just don't look at the absolute numbers. But is dilatation important? Well, when you go back, and we're now going back more than 20 years, this is one of the first defined surgical cohorts from Yale. So it was about thoracic aortic disease and how they behave according to the size. And you can see that when you reach 5 centimeters or you go up to 5.5 or 6 centimeters, everything gets worse. So there is more risk of rupture, dissection, and death. So this was the first time probably when people started to think, well, if the aorta is dilated, when do we decide if this person needs an operation or not? And this is where the first attempts at trying to define what are the surgical thresholds for aorta, where they came about. But around the same time, the IRAD, so the International Registry for Aortic Dissection, was set up. And of course, from there, we also learned just a few years down the line in 2007 that there were a lot of patients that were presented with dissection, even if their aorta actually didn't meet the thresholds yet for surgery. So that gives you an idea that yes, dilatation is important, but we started to have a glimpse on the fact that probably not every aorta is normal, and there are people that have a substrate that dictates a more aggressive and a more aggressive disease progression, and so would suggest that a more aggressive approach is needed from the medical and surgical point of view. So this is basically the basis of a genotype-phenotype correlation kind of exercise to bring in risk stratification. And this is what we are all, I think, in the field trying to work on and try to understand where we need to go with that. What are the next steps to try and keep as many people safe? When we look at inherited aortic diseases in general, we recognize that 20 to 25% are familial, so they run in families. Of those, 25% have a recognized Mendelian kind of pattern of inheritance, but only probably around 30% especially the non-syndromic presentation, have an identified gene mutation, and the current genetic panels in Europe at least will probably include 35 to 40 genes. What we tend to see in a pediatric clinic is you will have a number of inherited aortic diseases. Some of them are relatively common, not very common, but relatively common. Some of them are really, really rare. You might see a degree of a number of congenital conditions that can present with aortic dilatation, like in conotruncal malformation. In my specific case at Gosh, we have dedicated clinics for inherited conditions, so we tend to see less of those. And then there is something in between, which is probably the bicuspid aortic valves and the Turner syndromes, where there is an element of a genetically driven phenotype that also has some commonalities or some common management features with congenital heart disease. Why is it important to try and understand what is in the background? Is because the dissection risk is radically different between this condition. And while we recognize that some conditions like vascular EDS and Loeys Dietz, especially some specific very aggressive phenotype, they have a high risk of dissection, even in, maybe not in childhood, but in young adults for sure. Then there are others, like think of a bicuspid aortic valve with no valve disease and no aortic dilatation, where the risk of aortic dissection is much lower. So it's about, again, trying to stratify the risk and set these people on the correct path in terms of surveillance, medicines, and overall surgical treatment. Of course, we started thinking we were looking Marfan, and now we understand that there's a lot more to it, and there's a number of different conditions that have some common grounds, and it is now recognized that there are mutations that belong to several different constituents of the connective tissue disease that can give you a predisposition to more aortic dilatation. So you will have your Marfan syndrome, Loeys Dietz, so the TGF-beta signaling pathway. You will have others that have a lot less of a syndromic phenotype, but think ACTA2, where only some very specific conditions will give you a syndromic systemic presentation, but all the others basically will have a completely normal phenotype, except the fact that their aorta is at risk of rupture even for very small or non-dilated diameters. So it's a very different scenario to just thinking Marfan. So people that when you come to clinic on a Wednesday like today, you can spot them in the waiting area because they're very obvious to be picked, and we'll talk a bit about that. So I'll touch on a couple of these just with a glimpse in how they look like, and then of course if there are any questions, I'm more than happy to go into details about some of the other conditions. So Marfan is probably the most well recognized and most well described nowadays. 1 in 3,000, 1 in 5,000 autosomal dominance, and mutation in the fibrillin 1 are picked up around 90 to 95%. The diagnosis is based, as mentioned already, on the revised scan criteria, which are very important, but can be less informative in children just because the phenotype might not be fully manifest, and we'll look at that in a second. There is variable presentation and some initial ideas around genotype-phenotype correlation with, for example, a more severe phenotype in what was called the neonatal domain, so early onset and severe phenotype in mutations that are between the exon 24 and 32, and then some more genotype-phenotype correlation in dominant negative mutation or up insufficiency. 80–90% of the morbidity is caused to cardiovascular disease, and that is not only limited to the aorta, as said before, but mitral valve disease, and we are starting to recognize these new entities like Marfan cardiomyopathies and arrhythmias that can come with that, sometimes associated with progress of disease of someone that had numerous surgeries or just related to the valvular disease, but sometimes as an entity in its own right. The median survival in the very old report by Victor McCusick in the 70s, the median survival was around 70 years, and now we know that it was around 30 years, and that is when there was no treatment and very little recognition. But we know now that probably the expectancy of life is very close to the general population, probably with a lot more morbidity in terms of medical needs, but still the quantity of life has very much improved. This is from Genentech, so it's a big North American registry, and they looked at the presentation of Marfan children, so 183 patients below the age of 16, and you can see that they are divided in tertials. I hope you can see it well enough, but I think it's a nice presentation of what you would expect in a child. So while your aortic root dilatation, you would probably expect to see it from early on, you wouldn't expect your scoliosis or the skin marks to be present from the very beginning. So this is where we think that if you see someone with a dilated aorta and a bit of mitral valve prolapse, you probably want to investigate, even if they don't look particularly Marfanoid. There's still a chance they might want they will eventually grow into phenotype. So there's been groups advocating to bring down the GAN score criteria from the 7 systemic score to 5 in children, just because you would expect that some of the features are not there yet. I think we can clearly say that if someone has an aortic root dilatation or ectopia lentis, these are probably the two things that you don't want to miss. You want to investigate that further. Aortic root dilatation in this particular group of people, so from Genentech, is present in around 90% of individuals by age 19, and 2 to 12% require aortic surgery in childhood, and our experience at Koch is very much in line with that. And what has happened through the years is probably we've changed the median age at dissection with the median age of elective surgery. So we've gotten better at recognizing people that need surgery. So once upon a time, the survival was around that age, and now it's probably the time where your average Marfan patient will require their surgery. But of course, and this is where some of the early work about working out for which diameters Marfan tends to dissect as opposed to the general population is something that, as seen before, has corroborated the idea that we now need to move away from a one-size-fits-all and try to include the genotype in risk stratification and surgical management. Loeys-Dietz, novel disease, only 20 years old, TGF-beta pathway, a number of genes have been recognized, and there are a couple more that have been recently added to the list in the recent Loeys-Dietz primer. The prevalence is still very much not recognized, autosomal dominant in the vast majority, bar APOE8, which is the latest addition that is passed on as an autosomal recessive trait. There is an overlap in clinical features, and in fact, this is how Loeys-Dietz got picked up in the beginning. So many patients that were felt to have a phenotype that was very much in line with Marfan didn't have a Fibrilli mutation, and this is where then the TGF-beta pathway was recognized to be an important causative have a causative role in terms of connective tissue disease and aortic disease. Generally speaking, it is a more aggressive presentation as compared to Marfan, with more diffuse vascular pathology that is not just limited to the aorta but can involve the middle-sized artery. The dissections tend to happen for smaller diameters and at an early age, and especially for the TGF-beta receptor 1 and receptor 2 mutation. The surgical threshold now reflect that in terms of the concerns about potential acute events at an early age. And of course, you have a number of other traits that are mostly musculoskeletal, and you can have midline leaflets, severe craniofacial features like bifid and cleft palate. But it's not unheard of that you have someone presenting, as Gianluca mentioned, with Marfan families. The same we have a TGF-beta receptor 1 and receptor 2 mutation, where actually they look more like FTAD. So people that have families that have more a vascular phenotype and less in terms of syndromic presentation. And here is just to mention what Gianluca has mentioned already about the vertebral the arterial tortuosity and the VTI as a predictor of potential events. And this is some data from MAC, the Montalcino Aortic Consortium. Again, the attempt at genotype-phenotype correlation and risk stratification based on your mutation. So how TGF-beta receptor 1 compared to TGF-beta receptor 2, and what happens in terms of events and elective surgery. And the feeling is that TGF-beta receptor 2, especially in women with a small body size size and syndromic features of midline defect, it probably confers a much higher risk than other TGF-beta receptor 1 mutation, for example. And lastly, we'll just mention something that is much less frequent in the I guess in the general clinics, but we tend to see quite a number, because in the UK this is a nationally commissioned service. So vascular redundance, it's due to a mutation in the collagen 3, and it has very subtle phenotypic features, and the problem is you are at very high risk of hollow organ or vascular ruptures that are often lethal. The features are usually include thin and translucent skin. Usually they tend to present to medical attention, either in adulthood more for a presenting event. In children, it's more because they have subtle features that include easy bruising, and sometimes it happens that they come to hospital and they are investigated for a non-accidental injury, because they tend to present in quite dramatic ways. What is important bit with vascular EDS is we know that events tend to start to happen. There is a big jump up in terms of the amount of event, especially in adolescents and with boys. This is very old, so I think we don't have up-to-date data on what is the current vascular EDS population out there, but this is one of the first systematic reports from around 10, 12 years ago. It was 1,000 patients that were genetically diagnosed in Washington, so it was all comers with genetic lab, and you can see that having vascular EDS gives you a very high risk of premature death starting from the second decade of life. And this is just to reflect the events, as said, during adolescence, that it seems like, especially males, and not because of dangerous behaviors, but just because it seems they generally have more events, and there is a theory behind the role of male puberty and the potential protective effect of estrogens with EDS events. I will just very quickly mention this is another paper from the Montalcino Consortium, where the other mutations that you might have heard of. So at the bottom you see your Loeys-Dietz mutations, and at the top you will have your non-syndromic presentation, so ACTA2, MILK, and PRACAG. And this was probably the first systematic description again of acute aortic event in terms of type A and type B dissection and elective surgery for this particular phenotype. Which has informed, as mentioned, the fact that the current guidelines, both the American and European, they're now taking a lot more into account than just the sheer diameter. So you now have different thresholds for imaging, for medical therapy, and for surgery, depending on your genotypes. And it's the first time this has been taken on. And what's more, you can see here Marfan, Loeys-Dietz, and non-syndromic. And for Loeys-Dietz, you even go down to the specific genetic mutation, and it is felt, as said before, the TGF-beta receptor 1 and receptor 2, especially in the presence of a particular of risk factors, they warrant surgery for a threshold at 40 millimeters, which is radically different from a bicuspid aortic valve that would be operated on at 55. So this is where all the work that has been done in the last 20, 30 years and the understanding about the genetic background has really given an advantage in terms of management and guidance for care. And this is where the difference is seen. So this is for Marfan, as said, on the left-hand side panel, you have John Hopkins data from the 70s, and you see that nowadays the curve of survival, the Kaplan-Meier for survival for Marfans, has radically changed, and this is down to advice and lifestyle, avoiding things that are patently dangerous, of course, medicines, and I'm sure Simon will talk about it, and novel, not so novel, but more surgical techniques that allow for lower morbidity after you needed aortic surgery. And for the first time in the last couple of years, there's been a huge effort from the American colleagues and us in Europe to try and look at cardiovascular management for children with aortopathy in Marfan and in other conditions. So that's our next piece of work with Laura and others to look at the rare genes so that we can better define risk for children. Most of what we do is taken from adult practice, but yes, we are trying to see if there is anything that we can learn from our own experience and better guidance and management to be put out for children. Thank you.
Thank you, Elena, for this excellent presentation. It's always a great challenge to have to talk about so many genes and diseases in such a short period of time. I have some questions for you, but before I start with them, I would like to remind all the participants that they can share their questions through the Q&A in order for us to be able to see them and to post them to the speakers. Elena, as I said, I have a few questions, and I think that you highlighted very clearly the importance of risk stratification. You talked about the genetic background. You also mentioned that dissection is rare, and you showed how rare was. But of course, it's important that we still pick up those children at high risk to maybe manage them also a bit more in an more aggressive way. And in that sense, in terms of risk management, I was wondering, do you think that besides the genotype, that there are other aspects that we can take into consideration, for example, imaging of certain phenotypes that we could take into consideration to better determine the risk of a concrete child?
Yeah, I think that's the next step, really. So now that we've understood that there are some genotypes that put you at increased risk, when you look at them, you also, and you see enough of them, you also immediately recognize that not everyone is at the same risk. So you will have your Marfan patients that tick along and their aortas actually don't grow very much through their pediatric surveillance, and you transition them to adult care, and that's it. And you've done a good job if you've put them on medicines and you've kept them stable. But you also have the ones that require surgery very early on. And I think the first step was distinguishing between a Marfan and a Lois Dietz, for example, because of course, not even having that piece of information, of course, you would just see that someone tends to progress more quickly. I think there's a number of interesting bits in terms of phenotype, and that's where most of the research, I guess, is concentrating in a minute. And there are some things have been mentioned already, and I think they're quite useful. And that is where the effort is going, and there will be more as time comes. But vertebral tortuosity, so having a diffuse arterial involvement that sometimes presents itself for arterial tortuosity gives you the impression that there is more pathology and it seems to be more quickly progressing. So that's definitely something that I would advocate for in terms of imaging surveillance, at least once to scan head and neck. As Gianluca was saying, we do it routinely for all the high-risk genotypes. So I would probably say all the Lois Dietz, all the vascular EDSs to make sure that we're not missing on anything. MAD is also emerging as something that doesn't only confer risk of mitral valve disease, left ventricular dysfunction and arrhythmia, but also children. We've seen in our own data, both children and adults with MAD tend to go to surgery quicker, and their aortic dilatation seems to progress much quicker than the ones that do not have MAD. So again, the correlation at the minute is not quite clear. What is the correlation between MAD and the pathogenesis? But there are definitely markers. It's been advocated in the guidelines, the length of the ascending aorta, as opposed to just looking at the shear diameter. So there are a number of things that can be implemented and are emerging as risk factors. And you see it, for example, all the risk stratification that is done in Turner's when you have a specific genotype. So when you have your monosomy X together with having had congenital heart disease from the beginning, having had a coarctation repair. So there's a number of, I think we're moving more and more into describing this cohort in a lot more detail and being able to pick up which are the bits that you can see from the outset and might dictate a more aggressive phenotype further down the line. So I think depending, when you narrow it down, you will see that in that specific genotype, you might have clues that help you out in saying this might need surgery sooner rather than later. I don't know that it's all written on black and white yet, but we're starting to get a feel for that.
Thank you very much. That was very clear, all the different aspects that we can take into consideration to better risk stratify for our patients. We have a question in the chat regarding vascular EDS. I think that we all struggle a little bit with our children with vascular EDS. You showed indeed that there are not so many vascular events in childhood, but some will have vascular events. And the question specifically is like, how should we follow these children? Do we need to do regular echocardiographies? Do we need to do MRIs? And how often would you propose to do this imaging techniques?
I don't know that there is a real answer to that yet, I think. So I can tell you what I do. Definitely we scan them, and we scan them with echocardiograms probably every year or every other year. And in our population, that is now around probably 80 patients, we have 4 with a degree of aortic dilatation, which is something that is not really well described, but we have some young patients with a degree of aortic dilatation that, again, when we think about what are the red flags to think, is this patient at more risk? Of course, you would think that vascular EDS don't dilate before dissecting, but they do dilate. And when you look at them systematically head to toe, they're also the one that seem to have a more severe phenotype altogether. So yes, echocardiograms probably yes. I tend to scan them head to knee every maybe 2 to 3 years. Can be extended more, and some of it is also down to the family's preference. So if I have someone that tells me I freak out every time I need to come to hospital because I'm worried about the news that you're going to give me, am I going to change management based on that scan? Potentially not in vascular EDS. So some of it is tailored to what is the family preference. I haven't so far found anything that was actionable. So we do scan them, but that I changed management based on findings on the imaging, I haven't. Did I have patients that had aortic events? Yes, I did. Could I prevent them? No. So I think it's still very much one of those diseases where we can offer the surveillance, we can offer medicines, and I tend to offer medicines quite early on. By age 8 to 10, I tend to offer celiprolol, and if the family is happy to accept it, I put them all on celiprolol if tolerated. They're also the cluster of patients that tolerate medicines less well as compared to all the other ones. So sometimes I'm very limited to the amount of medicines that I can give. But I would advocate for screening them if they're happy. Even I think at the minute we're still building our knowledge and trying to, that risk stratification will only be possible if we pick the red flags that might help the next patient that we see in clinic.
Okay. Thank you, Elena. Just maybe a very short question, because I think we need to move on to the next speaker. When you speak about MRI on vascular EDS, from which age on would you start doing an MRI in these patients?
When they can have it awake, unless there are concerns. What I've done in the past, if someone presented with an acute event, say a hollow organ, a bowel rupture, then I would screen them vascularly just to make sure that there is nothing else going on. Outside of patients, which is probably 20-30% that present with an acute event in childhood, outside of those 20-30%, all the other ones I tend to scan when they can have the scan awake, so by age 8 or 10.
Okay, perfect. Thank you very much. I think for the sake of time, we should move on to the next speaker. Andrea, please go ahead.
So thank you very much for also like this amazing presentation. And I am very pleased also to present Dr. Simon, the host from Ghent, who will give us also a very, very interesting talk, and he will speak to us about the practical management of aortopathies in children. And please feel free to ask any questions in the Q&A, and we will try to answer all of them. Thank you very much, Dr. Simon. The floor is yours.
Well, thank you for the nice introduction. Thank you as well to the previous speakers who have made my job a lot easier. I hope I won't have too much overlap with the other speakers, but it should be okay. So today, I don't know if you can see my slides okay. I assume so, yeah. So today I'll give a short concise overview of management strategies for pediatric aortopathies. Slides. My presentation will cover three main topics, so imaging and follow-up, treatment options, including medication and surgery, and then also a brief overview of activity and exercise recommendations. I'm going to mainly focus on genetic aortopathies and the management of aortic dilatation itself, extra-aortic manifestations, and for example, vascular Ehlers-Danlos syndrome. I won't discuss in detail because they require really a separate condition-specific approach, and this would lead us too far and would not be possible to discuss in 20 minutes, sadly. So the overall goal of treating aortopathies in children is, of course, one, to reduce the risk of aortic dissection in children. However, as Dr. Chervi already said, this risk is relatively low. So our management is also primarily aimed at delaying the need for surgery as long as possible. As was mentioned before as well, pediatric data are limited, and most evidence comes from studies in Marfan syndrome, and the other non-Marfan aortopathies are rather limited. Therefore, my presentation is largely based on expert opinions. As Dr. Chervi already showed from European and American guidance documents, as well as from our own local experience, of course. Important to know is that currently the European document encompasses only the fibrillin 1 related aortopathy, while the American version encompasses multiple genes, but I'll point out areas where recommendations might differ or where evidence is limited. In addition to preventing aortic complications, maintaining quality of life is essential, of course, as well. This specifically also highlights the importance of multidisciplinary follow-up in our patients, which immediately takes me to my next slide. So children with conditions such as Marfan syndrome, Lewis-Dietz syndrome, but also ACTA2 aortopathies benefit from follow-up by multiple specialists. So even in the absence of, for example, obvious skeletal features, issues such as joint hypermobility, and so on, may require physiotherapy, and there are also other specialists that are usually needed. So at our center, patients are seen in a dedicated multidisciplinary clinic, allowing coordinated and consistent advice. So, for example, regarding physical activity, and this in turn improves clarity for both patients and clinicians. As you can see from the image here, we see the inner circle portrayed here as the really necessary colleagues for every visit, or at least once a year, usually, depending on the specific case and the specific patient, while the physicians on the outer side, we usually consult in specific cases or in specific genetic diseases. As was already pointed out by Dr. Chervi, so again, making my job a bit easier. Before I'm going to go to discussing the imaging and treatment, I would like to again emphasize the importance of establishing a genetic diagnosis whenever this is possible, because disease progression and risk profiles do really differ between even genetic aortopathies. So again, as Dr. Chervi already said, and this also alters their management, of course. So transthoracic echocardiography is the first line imaging we use for follow-up in children. Measurement should include the aortic annulus, the sinuses, and the sinotubular junction, as well as the ascending aorta, the aortic arch, and the descending and abdominal aorta. In pediatric patients, measurements are preferably obtained from inner edge to inner edge during systole. Leading edge measurements in diastole are acceptable depending on local practice, although pediatric reference values are more limited in this case, and most data is actually on the first method, so the inner to inner. Measurement should always be taken perpendicular to the vessel to obtain the best diameters. Specifically for the ascending aorta, measurements are preferably taken at the level of the right pulmonary artery. For the arch, so both the proximal and distal section can be measured, but in this case, it's mainly the fact that you're consistent with your measurement and where you measure it that is key, of course. As mentioned before, routine assessment of the descending aorta and the abdominal aorta is necessary as well. For the descending aorta specifically, this is easiest and most reliable from a modified apical to chamber view at the level of the left atrium, as is shown in the picture here. As pointed out again by Dr. Chervi as well, in an echo report, it's not important to only show the absolute values, because in children, they don't always say as much, but also z-scores, so a standardization should be reported. So for systolic measurements, the Lopez z-scores that I've shown are preferred by both the European and American societies. While for the diastolic measurements, the Compens nomograms are the most commonly used. The most important part about using z-scores is actually that you're consistent, one in, of course, your measurement method, but also that you stick to one z-score method during your follow-up, because of course these measurements can differ between methods, and if you alter your management on it, it should be the same one that you're using. In addition, during transition to adult care, measuring the aorta and z-scores according to adult methods as well as the pediatric ones may be useful as well to facilitate the transition to adult care and make sure that they have some previous values according to their methods as well. Follow-up intervals vary slightly between guidelines. For example, whether intervals longer than 1 year can be justified or not, which is, for example, not mentioned in the European guidelines for fibrillin-1 aortopathies. In general, yearly follow-up is recommended with more frequent visits once moderate dilatation is present, or in patients with high-risk genetic variants such as TGF-beta receptor 1s and 2s and ACTA2 aortopathies. We're also going to start following them up more frequently much earlier on. More frequent follow-up may temporarily be necessary in cases of periods of real growth spurts, since this, of course, has impact on the aorta as well, but also during titration of medication or during periods of rapid aortic growth. In patients that you see for the first time, it may also be useful to arrange a second visit after 6 months or earlier, just to be able to assess aortic growth, since before you only have one measurement, and it can be useful to see how fast the aorta in this specific patient is growing. Since echocardiography, of course, provides only limited visualization of the entire aorta, further imaging is often required. MRI is preferred usually due to the absence of radiation, but while CT is mostly used in cases of acute situations, so suspicion of an acute aortic dissection, or of course when the MRI itself is not feasible due to fear or other factors. For specific cases such as surgical planning, such as, for example, the Beer surgery, which we'll talk about a little bit more in detail later, but also as Gianluca showed, specifically sometimes after surgery to really visualize some aspects in detail, it may be necessary to use CT as well. In general, in patients with Marfan syndrome, it is technically sufficient to visualize the thoracic and abdominal aorta. However, since, as was said before, tortuosity of the neck of the neck vessels is considered as a risk factor for aortic events, and some patients still present with peripheral aneurysms, neck to pelvis exams should be considered in Marfan patients as well, at least once at baseline. In other syndromic aortopathies, such as Lewis-Dietz syndrome or such as ACTA2 aortopathy, a head to pelvis examination is necessary to exclude cerebral and peripheral aneurysms, but also, for example, to really exclude, for example, Moya-Moya disease in ACTA2 aortopathies. As was stated before, but also as Gianluca and Dr. Cervi showed very nicely, for both Marfan syndrome and Lewis-Dietz patients, they can have pronounced vertebral tortuosity, and this is an independent risk factor for both surgery, dissection, and mortality. So this is something important to take into account and evaluate at least once in these patients. The extent and timing of imaging depend on the underlying diagnosis, of course, and risk profile specifically. In lower risk patients, imaging can often be deferred until adolescence, or in case of normal diameters, even until adulthood. In this way, we can prevent unnecessary sedation, which is often required in very young children. Higher risk conditions require imaging at baseline, but again, this is usually modified depending on risk factors. Repeat MRI is typically performed every 3 to 5 years, or more frequently, as is shown here, in the more high-risk cases. Of course, other factors will play a role in how frequent you perform your MRIs. For example, insufficient echocardiographic views or very large aortic diameters nearing surgical thresholds will necessitate earlier imaging, while patients without any cardiovascular involvement and in which the affected family members also only have mild cardiovascular involvement at adult age, this may prolong these intervals or even delay the first MRI until an older age. As was said before, of course, not only is it important to follow up the aorta, there are several other specific aspects that should be followed up. As Gianluca already showed, for example, mitral aneurysm disjunction and mitral valve prolapse need to be diagnosed, since this is a risk factor for both arrhythmias and mitral valve surgery, and the extent of it even portrays into the aortic events. Further MRIs or additional sequences may also be needed to evaluate either valvular disease or cardiac dysfunction, or as Gianluca as well said, to evaluate, for example, fibrosis or extracellular volume. Since patients with aortopathies are at higher risk for atrial and ventricular arrhythmias in general, a load threshold for Holter monitoring is necessary, sometimes even in the absence of true symptoms. Exercise testing as well may be useful to evaluate either treatment effect or to evaluate the effect of exercise on blood pressure in specific patients and in specific cases, of course. Of course, most children with aortopathies will eventually require some medical treatment to slow aortic growth. In this case, beta blockers and angiotensin receptor blockers are the main pharmacological options, with atenolol and losartan being the most commonly used agents. Currently, there's no strong evidence favoring one strategy, so beta blocker over the other, losartan or angiotensin receptor blockers. The most important part, regardless of the specific choice of medication, is that these should be titrated up to the maximally tolerated dose, and this even before you start to think about dual therapy or anything. You really need to go to the maximally tolerated dose of the first medication. There are several medications that are relatively contraindicated in patients with aortopathies. Both fluoroquinolones and calcium blockers seem to worsen aortic progression. And very important as well is that, for example, agents causing vasoconstriction and hypertension are thought to increase aortic wall stress. Of course, this is all very relative because one of the most frequently used examples in this case is treatment for ADHD, such as Ritalin, that is used. But specifically in our patients, we usually see that when we start ADHD treatment, this usually does not really lead to a significant increase in blood pressure. In addition, it's very important to know that ADHD is an important comorbidity in our patients, leading to decreased functioning, and it should therefore, of course, also be treated to improve their quality of life. That's why we usually do allow starting such medication, but of course, with the important notice that blood pressure should be followed up closely, at least in the first few weeks. But of course, in our patients, lifelong monitoring of blood pressure is important. Medication is generally initiated once mild aortic dilatation is present, as earlier treatment appears to be more effective. Dual therapy can be considered in moderate to severe dilatation in general. In patients with high-risk aortopathies or rapid aortic growth, it can be considered to start medication earlier. Of course, shared decision-making, shared decisions are always made in this case, and some parents may be hesitant to start medication when only mild or no dilatation is present. But in this case, it's always important to inform the parents correctly. Specifically for children with aortopathy, hypertension should always be treated aggressively, although I must admit that we rarely see hypertension in our patients. In children with aggressive disease progression, preventive aortic surgery may become necessary. This is, of course, with the aim of, on the one hand, reducing dissection risk, but also, for example, preserve valve function whenever possible. Many decisions are influenced by established risk factors for aortic dissections. These are, of course, the specific aortic dimensions, as well as rapid aortic growth or a family history of aortic dissection, usually at low diameters in that case. Valve-sparing root replacement using the reimplantation or David procedure is preferred whenever this is feasible. The remodeling or Jakob procedure has a risk of late annular dilation and aortic insufficiency, which is why it is used less. Newer techniques, such as the Pierce or the personal external aortic root support, as already introduced by Gianluca, in which we place a sleeve around the aorta in order to support it and prevent further dilatation. This has shown very promising early results, but long-term outcomes still need to be evaluated, especially in children. Of course, in cases that the aortic valve is not salvageable, an aortic valve replacement will be necessary as well, although this is usually not the case. Surgical thresholds are primarily based on absolute aortic diameters, with 50 millimeters being used in the lower risk aortopathies, such as Marfan syndrome and TGF-beta3 aortopathies. This was as well shown by Dr. Chervy, of course, that we see that above these 50 millimeters, the risk of aortic dissection really increases in these cases. Other aortopathies usually have a threshold of 45 millimeters. Additional risk factors, so as you can see on the right, such as rapid growth or family history, can further modify these surgical thresholds to 40 millimeters, or in really young children, even smaller. diameters. It's also important to take note that for valve-sparing aortic root replacements, grafts for patients with aortic annuli below 20 to 22 millimeters are generally not available. And for patients undergoing Pierce operation specifically, they should not have more than mild aortic regurgitation, since this is something that we can not address or cannot be evaluated even during the surgery. To finish, I wanted to spend a short time on exercise recommendations. So historically, clinicians have always been very careful with exercise in aortopathies, since exercise raises blood pressure and may raise aortic wall stress as well. However, recent data in both humans and mouse studies have shown that moderate exercise may actually improve aortic disease, as well as improve the fitness and quality of life in our patients with aortopathy. This leads me straight to an important aspect, which is often overlooked during consultations, which is to really encourage physical activity in all the children in our follow-up, even when aortic dilatation is present. When considering specific advice regarding exercise, it is always important to take into account the type of sport that is practiced, but also the level and the frequency of it. For example, performing karate is considered a power sport, but in young children performing it at a low level, this will not have the same effect, of course, as in adolescents taking part in a competition. In our patients, we usually try to make this a shared decision and try not to be too stringent. But in general, we try to advise against intensive competitive or contact sports. Other than that, below the age of 10 years, we usually do not restrict any further, since, as I said before, most recreational sports are performed at a lower level. What we do always communicate and mention to the parents is that it may be possible that we'll have to restrict these sports and have to restrict what we say further down the line as patients age or do present aortic dilation. Above the age of 10 years, true power sports are discouraged. And patients with dilated aorta, we try to avoid intensive peak exercises as well. Yeah, thank you. And I'm happy to take any questions.
Thank you very much for this excellent presentation, Simon. It was amazing. So we've got questions on treatment. First of all, in regards of the use of celiprolol and irbesartan. So we know that, for example, celiprolol is more like for the beats. But would you, or do you use it? And what are the doses that you are using of both irbesartan and celiprolol in your experience, or if any of the other panelists have any comments on those as well? Thank you.
Yeah, so in most aortopathies, we're used mostly to use atenolol and losartan, of course. So while celiprolol and irbesartan are most used and evidenced in VETs specifically, so vascular Ehlers Danlos. The most cases we use atenolol or losartan. So I must say that for the celiprolol, I don't know the doses by heart anymore because I don't really see a lot of patients with vascular Ehlers Danlos itself.
I can answer that, Simone.
But maybe Dr. Chervi.
I can answer that if you want. So celiprolol, it's a drug that is not particularly common in many European countries, and it's quite difficult to get hold of in the UK. And I think it's much more common in France, where the study comes from. It's given as a 200 milligram twice a day treatment in adults. It's very rare in my experience that even adults get to take the full dose. With children, as I said, I tend to start around age 10, and I would usually probably start 25 milligrams once or twice a day. And this is based on the fact that the level of fatigue that I tend to see even today in clinic with some of the vascular EDSs, they just don't manage to get, you have children of 5, 6 or 7 that are still in a buggy because they can't go through the day. They come home from school and they are completely exhausted. So if they tolerate beta blockers, they tolerate a very small amount. Now, last year, the ARCADE trial came out, which is the same group in France that originally looked at the Cipro. And I mean, the Cipro trial was 54 patients, so we're talking very small numbers. And they looked at irbesartan on top of ciliprolol in vascular EDS, and it seems to be quite beneficial to add a second medicine. Again, in my experience, I've only started angiotensin receptor blocker on top of ciliprolol if I had aortic dilatation. So in the few that I mentioned, again, very limited by the tolerability. I think this is a group where giving, while with Marfanelow SDs, I tend to give quite huge doses of medicines, and it's very rare that I need to decrease because of side effects. In vascular EDS, you're very limited with what they can tolerate. That's my personal experience.
Thank you. Are also, what are your views on treating the bicuspid aortic valve aortopathy? Do you know, because American guidelines talk about zeta scores above 4. Is there any approaches that in your center you have, or what's your usually your guidance that you use?
So you mean for bicuspid aortic valve, right? Yeah. So I think in that case, it really depends on if you, so in the non-genetic part, it really depends for us on the one hand what the familial history says, of course, and then on the other hand as well, where the specific dilation occurs. Since, for example, the ascending aorta is something that dilates much more frequently in bicuspid aortic valve, while an aortic root phenotype is much less common. And then there's no real evidence on when you should start medication in bicuspid aortic valve. But since this is usually a much more mild progression and do not tend to dissect as quickly, we tend to start therapy once they reach indeed a Z-score of 4 to 5 in the ascending aorta, depending, of course, again on other modifying factors.
I've got another question in regards of and also it was coming from one of the questions about the stiffness, pulse wave velocity in also like how does it change the management? Do you think in the follow-up with imaging this will play a role for the flow or measuring of biomechanics in the aorta?
Yeah, so there have been a lot of studies, certainly as of recently, both in bicuspid aortic valve, Marfan syndrome, and so on, looking at more in-depth measurements of aortic geometry as well as 4D flow and pulse wave velocity, for example. And we do see some correlation with, on the one hand, the progression of the dilatation, as well as aortic dissection, so truly events. But as far as real implementation wise, it's still very difficult since most of these studies are performed on a low amount of patients, and of course lately the events are not of that frequency that we can truly pinpoint one exact measurement or golden standards. But as far as we go, we try to perform as much as possible as well, pulse wave velocity and things like that. And I do think that it may play a role in the future as an additional risk factor. So, for example, in patients with really high aortic stiffness or aberrant 4D flow, that it may help us to operate some patients just a little bit earlier to avoid risk of dissection and further progression. But as of now, I don't think we're there yet.
Thank you. Yes, sorry, Laura. I don't know if well, I don't know if we're running out of time, but maybe I don't know if anyone else wants to comment on any other questions that other panelists want to comment on, or is there any so far it has been a really interesting webinar. Thank you all the presenters for the amazing presentations, and thank you, Laura, as well for the moderation.
Thank you, Andrea. I think indeed it has been an excellent webinar. Thank you very much to Simon, Elena, and Gianluca. I think we have indeed learned a lot about the importance of deep phenotyping, not only for risk stratification, but also for the identification of different risk factors. Obviously, the genetic background, how important that is. And I think, Simon, you gave a very nice overview on diagnostics, follow-up, and management of these patients. So thank you very much to all of you. And thank you very much also to the participants for your questions and for holding us with us until 6:30 in the evening, at least here in Belgium. Have a very nice evening to all of you, a very nice day to the ones who are in other parts of the world, and we'll see each other in the next webinar, I think.
Thank you, everyone. Bye-bye.
Thank you. Bye.